a lot really, but also it saves us as well in many cases not doing the FFA, even the ICG. It's very important really. If you look about uh, the OCTA, for example, here. About so this is uh, the ICG, the industry green. It's very important really to pick up the choroid because in the choroid, the fluorescein does not really penetrate and present well the choroid. So we use the industry green. Unfortunately, industry green is not available in many countries. But also, again, it's a very invaluable investigation in the condition of uveitis because it helps us in the diagnosis and help us in monitoring and follow up the response of the treatment. Okay, so but here, for example, this is a case of AMPI. Um, uh, so you look on the ICG in order to see these kind of the blockage affect the black spots. But when you do the OCTA, you will see it fairly similar. Okay, so the OCTA really is quite useful. We rely on it in the field of uveitis more and more. Fundus autofluorescence, I'm sure you have it if you have the fluorescein angiography. It's very important as well. It can save you many of the doing FFA. For example, this is like serpiginous choroiditis condition. So if you look here, you didn't need really to do the fundus autofluorescence, sorry, the fluorescein angiography to see if there is any activity on the edges. You can actually look on the fundus autofluorescence to see it. Okay, so it's quite helpful really in many of the, especially in the white dose syndrome, to do fundus autofluorescence. Sometimes there is a condition called mutes, multiple evanescent white dose syndrome. It has pathognomonic feature on the fundus autofluorescence because it's hyperfluorescent. Other causes of white dose syndrome, if you are in doubt, like AMPI, it will show up as hypo. Okay. FFA, as I said, very important to FFA. It will show you the actual edema. Here, the OCT is silent, but you have got the leakage on the macula. So this means there is activity you have to treat. Then you have got can you see what is this thing in the periphery? Anybody can say this fluorescein, what is the periphery? So it's big ischemia, this huge ischemia. So I've got vasculitis, as you see, and you've got, so it's a closure vasculitis, okay? And this is also a form of closure vasculitis, and there is papillitis as well. Okay, so again, so we are still doing the mapping and tracing both together. You look at the history, examination, grading type. You try to use the multi-image model to find out it can help you in this. But again, you need to do basic laboratory test. So when do you do this? You don't do the laboratory test for a case of acute uveitis unilateral, and that's it for the first time. You do it if it is bilateral. You do it if it's chronic anterior uveitis. You do it if it's acute recurrent anterior uveitis. So this means there is some process. Okay, so some process you're going to trace it by doing some workup. But any case of intermediate uveitis and posterior uveitis, you have to do the basic laboratory work. And the basic laboratory work, as I said, it happened in these cases. Then you can add on if you are really if you are digging in more in the case. So I've got the liver and kidney function test. You do the syphilis. Anybody can tell us why do we do syphilis? Although it's not very common like the old ages. So you do the syphilis, at least the VDRL or RPR, the basic level. Then if it comes positive, you go to the serology. So why do we do syphilis? Because it can present in any condition of uveitis, at any level, at any sign. So it can be caused by syphilis. Okay, so we need to roll it out. And the treatment of syphilis is straightforward. So you just give the antibiotic. Um, but very important as well to trying to roll out both condition. Okay, the TB and the sarcoid. So you need to do chest X-ray. This will help in both, and you have to do something for the TB, the laboratory for TB. Um, we use in UK for a very long time, since even I did my fellowship like 15 years ago. We shifted from the Mantoux test, the skin test, tuberculin test. We shifted to the EGRA, the quantiferin gold. Now there is a T spot. But when I went to Saudi Arabia, I found they still doing the Mantoux test, which I think is not bad because although it's obsolete in the West, but the Mantoux test, the skin test of the tuberculosis, it's not very good in its specificity, but it's good in sensitivity. Okay, so it does not differentiate between is it really an infection or it's because of the immunization. But it's very good as I said, in sensitivity. It will pick up anything. Okay, and in this kind of endemic area, we really like to have this kind of sensitivity. So once you do you have to do the Mantoux test as well. As I said, not in every cases. In all cases of posterior uveitis, intermediate uveitis, and some selective cases for anterior uveitis. Okay, low threshold for HIV, B, and C if suspected immunosuppression. So the issue here, which if you come out from this presentation with this kind of information, it's more than enough. This is uveitis. This is inflammatory process. This is immunological process. Okay, flare up. So you have to do immunosuppression. We'll come to it now. But before going to the immunosuppression, you have to rule out infection. Okay, and ruling out infection, it can be done by the investigation and the mapping. Okay. So if you are talking about if there is a picture of cytomegalovirus, acute retinal necrosis because of the herpes simplex or varicella zoster, if there is occlusive vasculitis, which is very common with TB, you cannot really go straight away to immunosuppression without staying some point and ruling out the infection. Okay. Sometimes because quantiferon gold, it takes about 14 days. So sometimes there is like a case of choroiditis and panuveitis. And the most common um, causes for these are the antagonists. Is it TB or sarcoids? So we have to roll out the TB. So sometimes you can't really wait for 14 days before starting the immunosuppression. Otherwise, the patient will go blind. So we used to do just chest X-ray to rule out the miliary TB, the active open pulmonary TB. Then we can start with immunosuppression. If we really find out after that there is like ocular TB or something like, so then you can do the anti-TB treatment afterwards. Okay, so even uh, even if there is infectious cause for uveitis, you still need to treat the inflammatory process. We need to do the immunosuppression using steroids or immunosuppression. Okay, the thing here that when you are going to use this, whether it's a sarcoids, it's a toxoplasmosis or TB, it just has to be covered with antibacterial or antiviral, okay, or antimicrobial treatment. So infectious causes, when we are going to to diagnose them, is not to delay the immunosuppression, no, but we use it, but in cover with the antibiotic. Have you got this main point? Okay. When we treat these kind of uveitis, again, it depending on the level, the type. For this reason, it's very important to find out the type, the grading and type, because not only because of reaching a specific diagnosis, but also to direct which kind of immunosuppression, which extent, which method you are going to use. Okay, if it is a case of anterior uveitis, we don't start with oral steroids. We start with the normal eye drops, the topical regimen of steroid eye drops, whether it's Maxidex or Prizol. We go to harder like the Prit 40, the prednisolone 1%. You do it like every hour for 2 or 3 days, then every 2 hours for 2 or 3 days, then on tapering regimen, one off every week. Sometimes, as I said, in case of chronic iritis, you have to keep the patient in the lowest dose as a maintenance. Okay, if it's one drop every 3 days, so that's fine. Why? Because eye drops can cause cataract and glaucoma. So the second level in treating the anterior uveitis, you can use subconj or intracameral. Sometimes, really, you go to the oral if you already cannot fix it by the topical or regional treatment. Intermediate uveitis is quite tricky because the eye drops does not penetrate very well to the vitreous, but we still can use the topical if it's low grade vitritis. But most likely we use regional. We don't go to the oral straight away. We use the orbital fluor. It's very similar technique like the periorbital anesthesia. So using the triamcinolone alone, you can use something called posterior subtenon. It's also like modification of this, but to go to the we usually go to from the upper side. Then we can give the intravitreal, whether it's the triamcinolone at the old age or even Ozurdex, like the recent age. Um, then we can have oral, especially if it is related to, if it is bilateral or associated with systemic macular edema, which does not respond to the regional treatment. Okay. Posterior uveitis, really you need to do the start with steroid. The good thing in a steroid, it's very good salvage therapy. Okay, it has it can have a very acute response. It can be like vision treating the vision threatening condition. It can suppress the inflammatory process straight away. It doesn't need a build up like 6 weeks like other secondary or tertiary agents. But the problem as in the steroid, as we all know, it's about the complication and side effects. You cannot sustain the patient on high dose of steroid more than 6 weeks or 2 months. You cannot do this. You are destroying his health because of his eye. Okay. So when we need to do another agent, like as you see the right side image, is all of the list of the new and old secondary agent. So first, if there is resistant activity, so the steroids itself does not suppress the inflammation, does not suppress the papillitis, does not suppress the vasculitis. Okay, still the especially invoked Kanagi, the choroidal ischemia does not suppress it, and you still have this kind of serious retinal detachment. All of these things, you start straight away. If there is a resistance or activity, despite of the high dose of steroid, then you insert another secondary agent. In vision-threatening condition, as I said, whether it's macular or papillitis, you don't wait for the secondary agent to build up its own course of efficacy. Or sometimes we know from the natural history of the disease that it's not easily affected by steroids, like Behçet, Voktakhana Harada, sympathetic ophthalmia. The I'm not sure if you have biologic like Humira in Kenya, but once it's really come to our practice, maybe 10 years ago, it made a revolution, and even the Royal College of Ophthalmology made a new guidelines. You don't really need to wait the secondary and tertiary agent until you go to biologic. No, you can use it straight away as a secondary agent. Yes, which is very helpful. Humira made, as I said, revolution in managing condition like idiopathic juvenile uveitis, arthritis, IgA. In kids, you can have this kind of you can give half dose or even full dose of Humira. Because can you imagine if you keep these kind of children in high dose of steroid, uh, so it will too much. And otherwise, we used to do the methotrexate and these things, which also can have very grave side effects in this kind of young age. Okay. Um, the last thing about the managing, it's as you see, it's we call it a steep ladder method of treatment. Okay, you start something. Also, depending obviously on your in the evidence base and your clinical experience and the natural history of the condition. It's not like Wolfgang Haradan. You start with eye drops or just give intravitreal injection. So, but the issue is you start with the lowest minimum, the minimum treatment as possible, go to the highest, and then try to get it down to maintain the patient on the lowest dose of non-steroidal immunosuppression. Okay, this is called a steep ladder. And when we insert the secondary agent, you insert the second agent, you increase the dose of the steroid, you suppress the inflammation, then you start keep the high dose of immunosuppression, the secondary or tertiary agent, and you start to wane off the oral steroid to the minimum. Then you start to take it off and get it down, or just keep it in a minimum dose of 5 milligrams. Then you start to get down the immunosuppression agent. Okay, managing complication. Um, high pressure. So high pressure with uveitis is a very common thing. And I've got three types. You need really to differentiate between them because it will affect your management completely. So you can have hypertensive uveitis. So it is the actual inflammation, the actual heavy inflammation of the white blood cells and inflammatory material in the anterior segment, which is closing the ankle orifices and increase the pressure. Okay. Or you can have a steroid response. Because we treat the inflammation with steroids, oral or topical or regional, you can have this high pressure. Or tropicalitis, like Boston-Schwarzman syndrome. So how to differentiate between the three from the history and examination? Because in hypertensive uveitis, actually the inflammation is high and the pressure is high. Steroid response, most likely the inflammation is low and the high pressure is high, okay, because there is a steroid response and it doesn't happen from the beginning. It doesn't come from day one because you have to use the steroid to cause it. Tropicalitis is very it doesn't have too much inflammatory signs, maybe what few cells or even no cells, but there is high pressure because the problem is not because of the blockage of the orifices, it's the actual inflammation of the trabecular meshwork. Does this affect your management? Of course, if it's steroid response, we try to lower it off or use the some of the IOP sparing steroid like Lotimax. Um, but if it is hypertensive uveitis, we know we still give the hypertensive eye drops. But the important thing is to lower down the inflammation as much as we can. Tropicalitis is a mixture between the anti-glaucoma and anti-ocular hypertension and some sort of weak steroids as well. Systemic macular edema, if it is unilateral, okay, we can use the intravitreal orbital fluoro injection, which is easy. You don't need to penetrate the eye, or intravitreal triamcinolone ozurdex. It is if it is bilateral, it's not really nice to give the regional treatment in both eyes. We give some short course of oral steroids. CNV, CMV can happen, as I said, with many of the posterior uveitis, with Wido syndrome, the PEC, punctate inner corridopathy, or TB, or sarcoids, or toxoplasmosis can happen with any of the posterior uveitis. Do you really use anti-VEGF or anti-VEGF with steroids? There is a discussion about this. Neovascularization is a very important thing because it's very common. Occlusive vasculitis, especially as I said in TB, which is I think endemic in our areas, Behçet as well. So you have to treat it, as I said, as immunosuppression, but you have to suppress the neovascularization. But our usual methods by laser, PRP, guided by the FFA. So you just burn the ischemic retina. Optic neuritis, as we said, is mainly about managing the inflammation. Um, Cataract is very important when you do the cataract in cases with uveitis, especially intermediate or posterior, even if it's not active, to give the short course of oral steroids, like 7 days of 40 milligrams, something. Okay. Okay. Now, how much time do we have, Dr. Hatem?
For the presentation, let's say within 10 minutes. Is it okay?
Okay. Yeah, that's nice. Because as I said, I know actually because as I said, that's for the last moment. I didn't really incorporate the images because most of the times I was trying to I was doing the Uveitis presentation at a specific level, but it's very nice to see the images and to have some commentary on it. So can you see this case of the it looks like the matter fat creatic precipitates. Can you see it's quite oily and whitish. These kind of KPs, creatic precipitates, the endothelial layer of the cornea, and you've got posterior
We don't
synechiae
see
as well.
your presentation.
Oh, sorry,
We don't see.
sorry.
Yeah.
Yeah.
Yeah. Share again, please.
Yeah, well, I'm talking about this one, the mutton fat keratic kippies and the posterior synechiae as well. Can you see here the nodules? Okay, so this called Bosaka and Kapi nodules, and this dilated of the vessels. This can show up in chronic or granulomatous anterior uveitis. Um, can you see these kind of KPs? Usually the KPs, as you see here, is in the one third because of the gravitation effect on the lower one third of the cornea. But if you look about these KPs, you will see them all around. Okay, and what we call it is stellate KPs, and this is very pathognomonic in a condition called Fuchs' iridocyclitis, and it's easily missed. But once you know it, you have to relax to much extent because you don't really because even if you use steroids, it will you'll not get rid of it. Okay, so there is an element of patience with this kind of inflammation you have to have, but you need really to be very meticulous in following up and managing the complications, especially the cataract and glaucoma. This is very pathognomonic feature of the viral anterior uveitis, the sectoral iris atrophy, stromal atrophy. Okay, and you can see the posterior synechiae as well. And if you look here, I've got corneal lesion because it's a spillover from the keratitis. Um, this case, this is fundus autofluorescence. It's very common with this is all one case. Okay. Yeah. So it present itself with hyperpoint spots which leaks massively. But if you look on the anterior the fundoscopy, you will see the subretinal fluid, the retinal serous retinal detachment. And if you look on the OCT, you will find again the serous retinal detachment. It's not CSR. If you look about the septae, the septums here, they are very pathognomonic for Vogt Koenig-Harada syndrome. Okay. Again, this can be anything. This exactly what I was talking about, the choroiditis. Okay, it's not really white fluffy thing, but there is some sort of vasculitis here as well. So as I said, if you have this kind of condition, so what I'm going to do, I need to do fluorescein angiography, fundus autofluorescence to find if there is any vasculitis, ischemia. I'm doing the mapping, I'm doing the cost tracing. Very important thing, we do the chest X-ray and TB. Okay, then we are trying to lower. Maybe there is a macular edema here as well, and there is some sort of inflammation of the optic nerve. So unless I'm very, if I've got strong suspicion about TB in this kind of condition, so I will go straight away, as I said, to anti-TB treatment. But the main thing is we need to put the patient on immunosuppression. Okay. Okay. This is case of. Do you think this kind of lesion is similar to this lesion? No. This is white, fluffy, and superficial. It's very superficial. This is retinitis, and you have this kind of the occlusive vasculitis, hemorrhagic vasculitis with BRVO as well as secondary. So this is very pathognomonic for Behçet. Okay, the retinitis and occlusive vasculitis, retinal vein occlusion, it can happen with it. Okay. But again, the Behçet, as we know, there is a Behçet criteria, the mouse ulcer plus two the genital or uveitis and one of the other signs as well. If you look here, okay, what is this? This is by far the most common cause of posterior uveitis. Okay, what is this? Anybody can tell? It's a scar, Stokes scar. Okay, it's a scar containing the cyst of the toxoplasmosis. But what about this lesion here? It is retinitis, but it is also choroiditis because it's quite elevated. It's not just superficial brush on the retina, like what you see in just chorioretinitis. So it's a new lesion, de novo lesion on the edge of toxoplasmosis. This is very pathognomonic, and it's usually associated with massive vitritis. So, for example, it's very once you see this, it's toxoplasmosis. We don't need really. We still do the labs, but we don't. You don't need to wait for results to start the treatment. Is it infectious or non-infectious cause? It is infectious cause. So you have to start the immunosuppression. You have to start the steroids, obviously, but because it's now getting to the macula, it's threatening, visual threatening. However, you can't do this without the anti-toxoplasmosis. The most common treatment we use the pyrimethamine and sulfadiazine. Sometimes we use the clindamycin. Sometimes we use intravitreal, and this is very important thing as well. The intravitreal management becomes really very reliable, and we use it very commonly now. Sometimes cases with birth shot, rather than giving the immunosuppression orally, I just give bilateral Ozurdex like every 6 months. So if this is a pregnant, it's very nice really to do the intravitreal dexamethasone plus the clindamycin as well, so you can save the baby. This is the same thing, toxoplasmosis, but it tends to be choroidal neovascularization. As I said, you don't have a fixed plan, a fixed diagnosis for uveitis cases. You have to be open from the start. The important thing is you need to do the workup very quickly in order to do the actual job of managing uveitis case with immunosuppression. Okay. The toxocara, as you see, the fibrous tract between the macula and the optic nerve. Okay. This called Dosian, the diffuse unilateral subacute neuroretinitis. So there is retinitis here, okay, but can you see the nematode here? And we can treat it with laser, we burn it with laser, but also we have to give the helminthic, albendazole or mebendazole. What about if this lesion really is on the macula or just close to the optic nerve? We use some sort of steroids as well. This exactly I'm saying. What you see, this is not the infection. What you see is the inflammation. Okay. Yeah, you can wait. You don't need really to use the immunosuppression now because it's away from the macula. But what if it is close to the macula? You can't wait for the anti-helminthic treatment and stopping the inflammatory process. And sometimes you stop, you kill the infection, but you still have the inflammatory process. Okay. The retinal brush, the retinitis, the vasculitis, the retinal hemorrhages, this system, CMV, cytomegalovirus retinitis, what's called margarita pizza, and it can lead to retinal breaks as well and RD. Okay. Um, I wish I could include I could have included the progressive outer retinal necrosis, which is the varicella or herpes simplex, but immuno suppression, like in HIV. Um, it's not really associated with too much hemorrhage. It's associated with too much retinitis and subretinal exudations. It doesn't have vitritis. I'm talking about the PORN, okay, the progressive outer retinal necrosis. This is something else. No, this is the ARN, the acute retinal necrosis. Can you see this kind of the brush infiltrates of the retina, and also this kind of hemorrhages. Okay, this is the acute retinal necrosis. When you have a picture like this, okay, the definitive diagnostic method is to take a vitreous sample and do PCR. It's very highly sensitive in virus condition. However, when you see this, or when you see this one in HIV, you don't wait. You just go straight away and treat it. You straight with oral or intravitreal. Um, for example, the CMV, we treat it with valganciclovir orally, or you can give the foscarnet or ganciclovir intravitreal. You give some sort of steroids. This is exactly what I'm saying. In HIV, in AIDS, yes. So, but you have to be very cautious, obviously, about these things. This is RD. So it needs vitrectomy, obviously, and into laser and to like to stop the propagation on the edges. This is very, it's called histoplasmosis, POHS, the presumed ocular histoplasmosis. It has a triad. It has like this punched out chorioretinal scars here, okay, all around. And this is the first of the triad. Then you have the peripapillary changes, atrophic changes. And third, there is absence of vitritis. Why absence of vitritis? Because it's very similar to another condition in White syndrome, which is called multifocal panuveitis and choroiditis. It's very associated with vitritis. So when you have something like this, so it's most likely the histoplasmosis, and it can be complicated with CNV. You treat it with the anti-VEGF. Okay, it's very obvious here on the FFA. Can you see the lashy appearance of the CNV? This can be anything. Seriously, it can be anything. So you go to by the stomach. It tends to be some fungal, but sometimes, as I said, in these kind of cases, if you are not in doubt, you have to take vitreous sample. You have to do the culture and serology on it. This candidiasis, you can see the retinitis, huge subretinal infiltrates of the candida. Also, this is very localized candidiasis. Okay. This is a TB. Okay. This is choroid. Can you see the choroiditis here? This exactly. It's not retinitis. Can you see the choroiditis here? It spill over something on the retina, but it's mainly the choroid space. And this atrophic changes, scars, and this is the vasculosive occlusive vasculitis with BRVO related lesion. Okay. This is macula star. Okay, and this is again subretinal infiltrates. So it tends to be syphilis, but okay. Again, syphilis, you treat with the anti-syphilis, the penicillin or the sparing the erythromycin or other things. But this kind of patient really need penicillin. Um, okay, this is like the white dot syndrome. This is exactly what I was talking about. This is white dot, but it's not really the actual choroiditis, but it can be similar to choroiditis. Um, Here, this is very pathognomonic, the fundus autofluorescence, as I told you about. The lesion becomes hyperfluorescent. This only happens in mutes, the multiple evanescent white dot syndrome, okay? Which is self resolving. It does not require any treatment, okay? Just observation. But this is a bit different. This is AMPI, okay? The the most common or the first one on the list of the Weider syndrome. Again, it's like choroidal placoid lesions, which is between the choroid and the RP layer. And you look on the FFA, you will see it start with hyperfluorescent, then hyperfluorescent in the later stage. But the ICG is very pathognomonic because they show them as black spots, like it's because of this ischemia actually. And this is leakage at the end stage of the latest stage of fluorescein angiography. Okay. This is serpiginous choroiditis, part of very important thing really. In any case, looks like serpiginous. You have to roll out the TB serpiginous choroiditis because TB can cause exactly this condition. And why do you do this? Because serpiginous choroiditis is very bad condition, very aggressive, and leads to blindness easily. So we use high dose of steroids and maybe secondary agent from the start. But if it is TB, it has to be covered by ITTB treatment. Okay, this is something we call acute macular neuroretinitis (AMN). Okay, it's self-resolving, and the OCT is very, very important in picking up these things. It's like droplet here, and can you see the actual lesion here in the out in the outer plexiform layer? Okay, this hyperdensity material there. This condition called azure. Okay, the adult outer zonar inflammation, and it has three layers. So you have got the blackout layer, which is loss of RP and retinal layer. Then you have the active edge here, and you have the normal retina outside. It's inflammatory condition. Do we know the cause? No, we don't know the cause. This is exactly what I'm saying. But we know the pattern. But even before the pattern or with the pattern, we know that this patient, once we rule out the infection, we need to immunosuppress it. Okay. Again, this can be this like choroiditis lesions. Okay, under CNV. What can be? Can be TB? No, but there is no TB. So if the patient is myopic, yeah, it could be White syndrome. It could be punctate inner corridopathy, especially if you do this, you don't find any vasculitis or anything like happening with the TB. This is exactly what I'm saying. So it's you build up your scenario, then you build up your strategy of treatment. So this kind of patient really is CNV. Shall we treat it with both combination with anti-VEGF and steroids? I'm usually doing this. If it's unilateral, I give Ozurdex and anti-VEGF as well. Okay, again. Um, So this kind of condition can be again can be anything, um, but there is CMV here, and this one it can be syphilis, it can be TB, but we are going to do the same thing as well. Okay, and if it's CMV, you have to treat it. We have to immunosuppress. We have to do the anti-infective if there is any doubt about the actual infective cause. Sometimes, as I said, we need to do the a vitreous sample and do a PCR if we are really totally in doubt what's going on. Okay. This is a case of multifocal choroiditis. Mhm. Okay. So again, and you have these things of black dot on the in the ICG. I'm not sure you have ICG. But the ICG can differentiate between, for example, it can be sarcoids or TB, but or it can be this, as I said, the multifocal. The ICG can differentiate between both because not only the other investigation, because in ischemia it will stay like this, so it will stay black and stay black at the end. But in sorry, it stay black, then it will turn out like staining at the end. But in the TB and sarcoids, and also the Vogt Kanagi, it will stay black for the end of the course of the test. Okay. This is something you can just see. Yeah, there are some abnormal foveal reflex here. If you do the OCT, you will see some. This is the RPE layer, and you have this kind of irregularity and infiltrative materials here. It's something we call retinal pigment epitheliitis or Krell's. It's self-resolving. Can you see how the OCT really is very important in these kind of cases? Okay. So again, this is like a CNV condition, all right, related to inflammation. Um, and this is a case of very extensive retinitis. It can be anything. It can be effective. It can be candida. It can be masquerade. It can be so. We need to do this kind of strategy. We need to rule out the basic infective causes. Sometimes we need to do the vitreous sample. If we are really not sure about if we rolled out the syphilis, TB, all of these things. Okay, so it's like inflammatory condition. There is no masquerade, there is no leukemia or something by doing the vitreous sample. So again, with this kind of patient, could be toxo, but extensive because of immunosuppression. No, it is not really immunosuppressed. this is the issue what we are going to do. Okay, but in all cases, you are going to do some sort of anti-inflammatory protocol. The issue is it associated with what, and how are we going to do it? Okay. Yeah, I finished now. So I'm not sure if any, I hope actually this kind of presentation can give this general idea and familiarity with this specialty. But if something to end with, two things. First, you need to put your own protocol of managing uveitis cases as an institution. So as I said, in most of the institutions, um, yeah, I'm going to look at now. If you are going to, most of the constitution, as I said, if it is anterior uveitis for one time, that's fine. As a general ophthalmologist, acute clinic, they can manage it. If it's chronic, bilateral, if it is associated with intermediate or posterior, it has to go to the specialist clinic. And secondly, you have really to make what you call patient-centric management. Okay, because the patient can be pregnant, the patient can have health issues, which you don't use this kind of treatment, but use the other. So it's all about the patient, okay, not only about the condition. No. When you do the 24, I'm just looking at the question. When you do the 24 on, we don't do the mantle. Um, okay, so we use 24 on or T-spot, but as I said, it takes some time, and it's not available in many of the it's not easily available in many of the countries. So mantle test, I wasn't really I wasn't feel right about it. But when I went to Saudi Arabia, really, I felt that it still has a role, and most of the big figures and advice don't really count on it, to be honest, the mantle test. But looking at
Actually, we have it in our institution. The
24,
quantiferon, yeah, gold test.
very good,
We
really,
do it
very good.
regularly. Yeah.
Yeah, that's good. That's good. Vitrel, actually, the Vitrel and RPR, they are not very, they don't have high specificity. They have good sensitivity, but we use them, as I said, it's for screening. Okay, so we use them for the first element. If you don't go for, if it shows up positive, then you go to the serology test. Okay, for trypanosoma pallidum. Yeah, we scan. Sorry, I didn't pick it up, but it's because we don't do it regularly. But we scan can have some role if you think really, um, uh, because most of the time you don't see the fundus. Okay, and in cases with viral posterior uveitis or a massive case of TB or sarcoid panuveitis. So you didn't see the fundus. So the B scan in this case will give you just a clue about the fundus. Um, if there is retinal attachment, obviously, but if there is no retinal attachment, it's really unlikely to give, but it will give us assurance that the retina is okay. Okay, but apart from this, we don't use it regularly. But as I said, in many cases, CMV, retinitis, and everything is cloudy. You don't see anything. We have to do the ocular ultrasound. Okay. Tamam. Yeah, I finished now. Thank you. Yes, Dr. Hatem, I went through all the questions. If there is any question or any comment, I'm happy to
Thank you,
receive.
Dr. Muhammad. Yeah, thank you, Dr. Muhammad, for this nice presentation and this informative lecture. It's really a difficult subject to go through, and so I think now it is something like lightening of the way to access the uveitis patient. Any one of the attendants here has any question? And then our colleagues also on online, if you have any question, anything to be explained, you kindly put it on the chat.
I think in the chat I had asked about how multiple sclerosis.
Yeah, there is a question from Dr. Mundia about kindly explain how multiple sclerosis causes uveitis, or the issue of the intermediate uveitis.
So basically, the associated with multiple sclerosis, yes, it's a demyelinating condition, but it can be associated with microangiopathies as well. Okay, so this kind of microangiopathies elicits the issue of immune response, and this is very common in vitritis. For this reason, and especially in cases with vitritis associated with peripheral uveitis on the retina. So it's a pathognomonic sign of multiple sclerosis, because the issue is the microangiopathies, okay, which can cause both the peripheral uveitis. It's called fan tree leakage on the fluorescein angiography, very specific form of it, like a tree, but also it stimulates the immune response.
So
And
it
in this
is
kind of
an
cases,
issue of
as I said,
microangiopathy.
we do it regularly. We have to do it, the MRI scan in these kind of cases. And if there is positive features on the MRI, so you have to liaise with the neurologist about treatment of these kind of cases. We still give the anti-inflammatory, but we should liaise with the neurologist, because this is the master of managing this kind of conditions. So we don't like to spoil his or her management plan.
There is another question from Murtaza Somji. What is the role of an optometrist in means the diagnosis of this disease?
The important role of optometrists is to have very threshold of picking up abnormal signs and referral. Okay, this is very important thing. I know that 95% of what I said today, maybe it will be very difficult to apprehend, but from the optometrist side, but it's very useful to know the framework of the specialty. Okay, but the most important thing, as I said, to have high sensitivity to pick up, for example, the ciliary injection around the cornea, which can be related to cornea pathology, or can be related to the anterior segment inflammation, and also to see if there is any KPs. These are things. It's a part of your natural expertise. Okay, but also you need really to know exactly how to pick up the cells and to grading whether the cells of the anterior segment and the cells of the vitreous. Adding to this, it's about managing, as you see from the managing uveitis, whereas too much thing about can be missed. High pressure, which can lead to glaucomatous optic atrophy, cataract, which really can impact the visual acuity of the patient. So these things also the optician can follow up the case of uveitis with. Regarding the posterior uveitis and the actual intermediate uveitis, to be honest, even for the general ophthalmologist to deal with it exclusively, it might be a bit risky, because many things can be missed or can go wrong. But again, it's very nice that if the optometrist can have a proper look on the retina, and if you see any retinal anomaly, it's very important to refer it straight away. We got many cases of uveitis coming from the optician referral. You know about the system in your case. We rely heavily on the optician referral. Sometimes we get referrals from our colleagues, but most of the time they come from the optician, who finds something abnormal on the retina or the vitreous or the anterior segment. Okay, so mastering the examination techniques, have a general idea about the framework of the specialty, and have low threshold of referral, and helping in managing complication. Thank you.
Thank you. No more question. Thank you, Dr.
Just I want to.
Okay.
It's a bit of comment and questions. I just want to share that for two aspects regarding Man-2-Tex and serology of syphilis. For Man-2-Tex, in my experience, I realized that when you have patients that have uveitis related to TB, sometimes the reaction is different compared to a normal reaction related to vaccine. The swelling, the diameter of the reaction is much important, and is also correlated with the response when you put the patient on TB. So to say that in the area where it is difficult to have to do a golden TB, Mantutex still have an important role to do. And also for syphilis, at the same time, observation and questions, because in the hospital where I worked before for 13 years, although it is not common to have a positive serology when you do a TPHA, but I can say that it is important to continue asking for it, because all those 13 years without doing a study, but I was recording, I only had 4 patients that after doing the VDRL and I asked for TPHA, it turned positive. So my question is to understand, despite the high prevalence of HIV, how come that serology of syphilis is now less compared to before? In your experience, what is your observations? And the second question is regarding your collaboration with rheumatologists when it comes to diagnosis of uveitis. Because for us, for example, we are in an institution where there are rheumatologists and a lot of range of investigation of vasculitis when we don't have a uvea specialist. So, in your experience, what is your thought about collaboration?
Can you say the first question again? Because I didn't catch it.
The first question is about syphilis. Despite the high prevalence of HIV, AIDS, now syphilis is lower. What is your experience in your practice there? Is it the same observation that it is rare to have a serology positive in uveitis compared to HIV?
No, we had actually one of the very strong indication about to do the HIV if you get any syphilis positive, because there is a strong association between both condition, as we know, because of the very similar risk factors. Sometimes in the serology, what we call the window of silence can happen with VDRL or even if RPR. This can happen with syphilis, and it can be related to many things related to the actual intrinsic history of the disease, the behavior of disease, can be related to the immunosuppression, as you said, sometimes low the CD4, so it will give you this silence. To be honest, in patient with HIV, it's if you get the VDRL negative or these things, it's important to go to the serology, the TPA or TPH. Because as I said, if you have a high suspicion of syphilis, we didn't go through all the details, obviously, but sometimes if you have this kind of subretinal infiltrates at the level of RPE layer, this is on OCT scan. This is very pathognomonic for syphilis. As I said, if you get many of the things, but there is no clinical or diagnostic line to connect between them. So even if you get the negative screening test, try to move to the more specific serology. But regarding do we get positive syphilis with positive HIV, even with CD4 count less than 400, yes, we get this. Regarding the second question about
the collaboration with rheumatologists when it comes to diagnosis.
There is no fixed rule, obviously. Yeah, of course, there are some condition like patient, if it has some condition which has systemic manifestation, the rheumatology needs to step in. The rheumatology is more equipped than us to apply the immunosuppression, correct? But the problem is if there is no, it has to be strong liaise and connection between the ophthalmologist and rheumatologist in managing these conditions. Because sometimes, as we see, we use biologic, use Humira, infliximab, just because of the eye. In case of Behçet, which is systemically look okay. Okay, it's the sarcoids. Everything is for us is fine, but the patient really has got a very high density pulmonary fibrosis and pulmonary symptoms. Needs to have high dose of steroids. So some condition is not a luxury to consult the rheumatologist. Okay, but it's not about that dermatology. Usually, dermatology has got the upper hand in special condition. Okay, for example, like Crohn's or ulcerative colitis, it should be with them. Okay, but you need to have a strong element of rule to tell the rheumatologist what is your need and your concern from the immunosuppression point of view. Okay. Secondly, uh, I know some practices in some countries, they don't do immunosuppression. They just leave it to the rheumatologist. It's not nice because the rheumatologist, any inflammatory process, any immunological, will give the full dose of immunosuppression. And as we see in managing our cases, it's not like this. Okay. So what it's very important at the end, as I said in the beginning, to know the actual context that you are working on and to develop up some sort of simple policy, what to deal with it. Okay, there are some elements that dermatology should manage, and you are the secondary rule. Some elements, some cases, it is the other way around. Sometimes, you manage yourself and you just keep the rheumatologist under knowledge, and the same will happen to you as well.
Thank you.
Okay.
Thank you, Dr. Muhammad. Let me check if there is any other questions. No, any other questions? Okay, thank you, Dr. Muhammad, for this nice presentation. Thank you very much, and I hope to see you very soon, either online or physically in Kenya, inshallah.
Inshallah, we're thinking about visiting Kenya. Inshallah,
Yeah. Welcome.
I'm very glad that
Karibu.
you added my name to give this kind of humble participation, and hopefully it will, as one of you said, it will shed some light about this complex pathway. And inshallah, if any problem, any complex cases, we can share in the future. Thank you.
Thank you. Thank you, Dr. Muhammad. Good night.
Assalamu
Alaikum salam.
We have today's sponsors who have sponsored our CME for today. AbbVie, formerly known as Allergan, which is a branch of Faraon Healthcare Africa.
Hello and good evening, everyone. My name is Jason Simi from AbbVie. As Sophia has introduced us, we used to be called Allergan, and we are a team of around 3 people. And we recently also joined by another person here called Sam. Sam, I guess you've been interacting with the doctors here. Then we have Pauline, also my colleague. I know most of you also know her.
The gene.
And then also John, John Orio.
The gene with John is Allergan. We not call him Obvi. We keep Allergan.
Nowadays we are AbbVie, but you know him as John Allergan. He's our professor. He's not here, but I guess he was supposed to go online. He's somewhere else on some other issue, but he might be hearing us. So we have products that are actually directly the topic of the day, and I'm happy. I don't know if Dr. Mohammed is still here. He mentioned most of our products like Ozodeg and also Humira and Predforte. We actually was supposed to have a presentation from our medical liaison on Ozodeg, because we are not allowed to market Ozodeg because it is not fully registered in our country. So she was supposed to do it, but she is not available. So we decided to at least choose a topic that might be of essence and also help us in this institution. You know, dry eye is a condition that most of you have interacted with, and our Professor John also has gone through dry eye for many times, but at least just to go briefly on it. I know also we don't have a lot of time, so I just want to go through it very fast. I know when you mention dry eye, most of the time, what comes in our minds is tear deficiency. We most of the time know that dry eye is you don't have enough tears on the ocular surface. But according to the studies that were done later, much later, we find that dry eye is not only the disease of the tear, it's not only tear deficiency. And that's why in 204, we had another definition where it was defined as a syndrome in which an unstable tear film is inadequately supports the health of the ocular surface, the film, and promotes ocular surface inflammation and stimulates eye pain. I want you to note inflammation of that definition. And in 207 also, the International Dry Eye Workshop were able to get another definition, and also you'll note something there. They defined dry eye as a multifactorial disease of the hair and ocular surface and the ocular surface that results in symptoms, discomfort, visual disturbance, tear film instability with potential damage on the ocular surface, but accompanied by increased osmolarity or hyperosmolarity, and also inflammation of the ocular surface. So those two, the hyperosmolarity and inflammation are the points I wanted you to actually focus on mainly, because that is what entails our products, the Optiv family. So generally that. So hyperosmolarity, the role of hyperosmolarity and the inflammation of the ocular surface, they play a lot of roles in dry eye, and that's why we are going to talk about Optiv today. And that is just a diagram that shows a representation of a destabilized tear film, where there is dehydrated epithelial layer, and also the tear film is dehydrated. When this process happens, it means that water is drawn from the epithelial layer to balance the osmotic gradient, and now leaves the epithelial layer dehydrated. So the epithelial cells are dehydrated, and when this process continues for a long time, there's inflammation, and later you might also have cell death. So I want to also talk generally on an issue called osmoprotection. Let me just put it on slideshow so that that is it. Yeah. Thank you very much. So osmoprotection is what Optiv entails, and that is what makes Optiv at least different from the other products that are in the market. And it's a new approach to treat dry eye by providing protection against hypertonicity below the corneal surface by rehydrating the epithelial surface. As I say, when there is dry eye, it means there's a lot of electrolytes on the ocular surface. So water is drawn from the epithelial layer, so leading to the water to be drawn from the epithelial layer to balance the osmotic gradient, so leaving the cells dehydrated. So this osmoprotection is done by small micro or non-ionic osmoprotectants or solutes. One of them is called L-carnitine, another one is called erythritol salts, and also we have glycerin in it that actually go deep into the epithelial layer. By doing so, they ensure that the osmotic gradient at the epithelial layer is higher than the surface, so water is drawn back to the epithelial layer, and this is how the process works. So in the normal dry eye, water will be drawn from the epithelial layer because the cells are now exposed to a hypotonic environment when there is dry eye. So When that process continues, the cells will tend to take in the solids, any other solids within the environment, to ensure that its cell volume is actualized. By doing so, it continues to inflammation, and that might lead to cell death because now there's less water, so it leads to inflammation, stress and inflammation that will lead to cell death. But now Optiv comes in here. The compatible solids that we've talked about are usually very minute, so they are absorbed. Immediately you put a drop in the ocular surface, it is absorbed into the epithelial layer. So by absorbing in the epithelial layer, osmotic gradient is raised, so water is drawn back to the epithelial layer, balancing the osmotic gradient and also lubricating the surface. So the first one was a dehydrated ocular surface or a dry eye representation. This one now is a normal ocular surface, a normal functioning ocular surface. The cells are happy, everything is going on in the normal way. So, and this is what entails Optiv. That other diagram that shows a representation of what happens now when the solids now are on the ocular surface, they are absorbed in the epithelial layer, and then water is drawn to ensure that there is an osmotic balance. And now, what is Optiv? Optiv is an advanced technology employing compatible solids in addition to lubricants to relieve dry eye symptoms. So now we talk about Optiv, the Optiv family. Now we talk about the Optiv family. And in Optiv family, I know here in Aga Khan, you have 3 Optivs, the Optiv eye drops, the Optiv Fusion, and Optiv Gel. But we also have Optiv Plus in the market. Okay. I think even the online guys are able to see. I don't know. Okay. So that is the Optiv range, and these are the ingredients, but I'll go through them here. This is how the Optiv looks like. No, all the names were changed to AbbVie, so this is the new box and how it looks. So it is actually a carbox metal cellulose, made of carbox metal cellulose, which is a lubricant and also hydrates the ocular surface and also does osmoprotection. So Optiv actually offers a dual mechanism of action by lubricating the surface and also rehydrating the epithelial layer that was dehydrated before. So rehydration is done by the L-carnitine, glycerin, and erythritol salts that go deep in the epithelial layer to ensure that water is returned in the epithelial layer to ensure there is osmotic balance, and now a dry eye is solved. Then the next one is Optiv Plus, and Optiv Plus now has a triple mechanism of action, because in its ingredients we have carbox metal cellulose, we have the osmoprotectants, the glycerol, L-carnitine, erythritol salts, and lastly we also have an addition of castor oil. So Optiv Plus is mainly for lipid deficiency dry eye patients. Usually have 2 types of dry eye: aqueous deficiency and lipid deficiency. Optiv eye drops is for aqueous deficient dry eye patients, but now Optiv Plus mainly for lipid deficiency dry eye patients because of the addition of castor oil that now supplements the lipid layer of the tear film. Osmoprotection protection is done by the osmoprotectants, and carbox metal cellulose does hydration and lubrication of the ocular surface. I want to spend more time here, but I'll be brief because this is actually like a shortcut to management of dry eye. You can give this to any type of dry eye patient because it covers the 3 layers of the tear film. The ingredients will cover both the lipid and the aqueous part of the tear film. And unfortunately, it's not available here in Aga Khan. We were trying to ensure that we get it here because actually studies show that 90%, almost 90% of patients suffering from dry eye will have lipid deficient dry eye or lipid and aqueous mixed. So you find that the bulk of the patients are supposed to go with Optiv Plus, but the normal or conventional way of treatment, you find even the products that are in the market, they go for the 10%, the aqueous deficiency dry eye. So all the other Optivs will be aqueous, but only Optiv Plus goes for lipid deficiency dry eye. And even in the market, I've not seen any other brand that claims to work on the lipid layer of the tear film. But if it is there, maybe it is one or two. But mainly we have the other ones that are available. So we are trying to see if it's possible to get it in Aga Khan, and your patients will really benefit.
Yeah, maybe just to interrupt you, I've already said it several times. Sometimes you are the pharmaceutical company, you are the one that are complicating things for institutions, because the institutions, the administrators, the financial people who have a power to say, yes, we bring this, they don't understand why you have Optiv and you have many, and you are still asking for. You give us headache to explain to them. Sometimes you explain, they don't understand. Meaning that, for example, now that you have Optiv Fusion and you have Optiv Plan, so why are you still continue supplying Optiv Plan instead of bringing Optiv Plus and say we are withdrawing this, we put this? Because if we have Optiv Fusion and we have Optiv Plus, we are good.
Very true.
It is difficult to convince administrators, those people who will make the decision for product, to come to understand. Already even different name, the artificial chairs are so many. That is one of the components. And you want to bring one for the same company that has the same name, and you are trying to explain to them this one have this benefit. It's really a difficult task.
True. I really understand, Doc, and it is not only in Aga Khan. Many other institutions have had such a problem. But Optiv eye drops came first. It was the first one to come. So most of the institutions will have Optiv eye drops.
Yeah, we do it.
Yes, but Optiv Fusion Plus and the others came later.
Yeah.
So if you had already Optiv eye drops, it might not be able. We might not be able to get it out of the institution to bring the other one.
No, it will be easy.
It will be easy.
They will understand that logic.
Okay.
But for you bringing again additional on top of it is more difficult.
I understand. So maybe
I tell you from experience, for discussion with administrators,
yeah.
their language that they understand, you expect them to understand scientific things. This.
Yes. 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 That is actually a great. We can still try and have some studies and bring, and also see how we can trade in the two, because we might want more of Optiv Plus than the Optiv eye drops. Because of
Sometimes you bring it in our habit of prescriptions, like if someone like me, you bring in, you have Optiv Fusion, Optiv Plus. I've been fighting to bring it, and then now they are supplying Optiv, and then it gets to expire.
True.
And then they'll ask you, why did you bring this? Why now we can't sell this? You make life difficult.
No. It has happened in one institution, and we did that. We ensured that we removed at least one and replaced with the other one. So and it has worked. They have Fusion, they have Plus for lipid deficient, and they have the gel for the night. So the three now work very well for the institution. So maybe we can also do that for
because next time you bring Optiv Plus and then you send Optiv the gel, can you bring the it's just difficult to make things like that work.
Doc, it is very much noted, and we are going to work on that. Thank you very much. Then just to mention briefly, because I know time also is not on our side, we also have Optiv Fusion. This is available here. This is a bit different from the other Optivs also because it has two polymers. So it has hyaluronic acid and CMC. So how it works, they make a bridge matrix on the ocular surface that leads to an extension of hydration for a long time. And also for patients with contact lenses, this will be something that they will love very much because hyaluronic acid also it will do hydration on the ocular surface and for a longer time. So for contact lenses, this one is the best. Dosage for dry eye is usually when the patient needs it, but for Optim, we recommend around 4 to 6 times in a day, depending on the severity. But we also recommend for the first like 2 to 4 weeks. Then after that, just put in when you feel signs and symptoms. When you feel the signs of dry eye, you put in. So some people would say they use twice a day, sometimes 3 times a day. Some people will say once a day. Yes. Then lastly, we have Optiv gel. Unlike the others that have 0.5% of carboxymethyl cellulose, Optiv gel has 1%, which is a bit thick and a bit viscous. It will stay on the ocular surface for a longer time. It's recommended to be used in the night, but also for severe dry eye, patients can still use it in the day. Although it blurs vision, not for a long time. You put a few blinks here and there, like 5 minutes, then it will be clear. So you can still use it in the day, but recommended mainly for the night. All these Optiv are that of protection and lubrication part. So they do the dual action, the triple action, all of them. Just to mention lastly, all the Optives are preserved by purite. Purite is an oxidative preservative that is very well tolerated. Usually, it is when you put in the eye, it is exposed to light, it decomposes. We usually say all Optives are preservative free in the eyes. So all the contactless patients, anybody who do not want the preservatives, actually that can help them very much. Also in dry eye, mostly preservatives are discouraged because they work against what you are working with. So usually when the benzalkonium chloride, which is a detergent preservative, will do dispersion of the lipid layer and also leading to dry eye. So it's better you have a preservative free or an oxidative preservative. This is just a representation of where how the preservatives work on the ocular surface. The first one is where there's no treatment. The second one, you see purite, is almost the same as no treatment, or as if there is no preservative at all. Sodium perborate is also an oxidative preservative, but at least it reaches on the eye. Purite doesn't reach in the eye. Immediately it exposed to light, it decomposes. So that is an advantage. But the other side, polyquad is another version of benzalkonium chloride. So you find most of the product with that will lead to other issues. So thank you very much for that time.
Thank you all for listening and participating. Have a great night. Bye.
Thank you. Thank you.